Dr. Kumar sir, KS.
Good afternoon. I would like to introduce myself as Dr. Kumar in private practice, in solo private practice in Bangalore. My paper is about a new objective pupil assessment device. Now, if we look at the various objective devices that are available for assessment of various parts of the eye, we have an objective assessment device for almost everything. We now even have an automated gonioscope available. We have modified devices to image the anterior segment. But if you look at assessment of the pupil, we almost have nothing. We only have the humble torch, and most of it is, that too is subjective. So this was what prompted me to do this. Pupillary reactions, as we all know, is pivotal for the diagnosis of not only various ocular disorders, but is key to managing neurological issues. It's often treated lightly or overlooked in our busy clinical practices, and patients many times subjected to needless imaging and lab testing. That's just the pupillary pathways. Now, when we look at manual pupillary reactions, they are mostly subjective and qualitative in nature. It is prone to inter and intra-observer variabilities. One study found it to be as high as 39%. Depends on so many factors listed there. There's lack of standardization and lack of documentation for review. It is not that there are no objective methods. We do have this list of objective pupillometers available, but they are way too expensive. And there are a few smartphone-based devices that are too cumbersome also. So these are some of the images of the already existing objective pupillometers. You can see that significant amount of assembly that is required for even the smartphone-based device. Now, this is another thing that is available in the literature, but this is a software which costs $40 for every month, and if you buy the software for 1 year, he offers you a discount of $20. So everything is really not user-friendly. Now, coming to the basics of photography with visible light, when we image the pupil with visible light, there are problems with visibility of the pupillary border because of the lack of contrast. The dynamic and static responses of the pupil cannot be recorded. And more importantly, corneal opacities, if the patient has one, can interfere with the results. This is a picture which we can get with the regular photography using regular light. Now, when we use infrared light, the light is not visible to the naked eye, and there is very minimal stimulation of the pupillary reaction by the infrared light itself. Infrared light is illuminating the eye. The eye is flooded with infrared light, and that is the reflections from the tissues is captured by the infrared camera. It obtains data in different lighting conditions from total darkness to bright light, and can penetrate mild to moderate corneal opacities, as we can see. So our device consisted of the smartphone with an app, that is the app that we used, a bike mobile holder, and an infrared camera. This is the image of the infrared camera. And these are the specifications of the camera. And these are pictures showing the assembly, the front view and the side view of the device. The methods that we used was, we used the camera flash itself as the light source. Initially, we tried using a battery, but that needed another personnel to shine the torch. So we used the mobile camera flash itself as the light source. And the data was recording using the interface USB app, either as snapshots or as videos, and the pupillary reactions can be reviewed and analyzed later. These are some of the snapshots that we got of patients. Patient with the pupillary reactions with the ambient light off and the ambient light on, or a rare case of bilateral ADIS pupil showing poor response to light and tonic response to near. Another patient with a chronic ADIS pupil which had gone into what's called as a little old ADIS. This is particularly of interest. Look at this corneal opacity in this patient, but this is the image that you get with an infrared light. You can get very clear images, and this is the reaction, the picture taken after the pupils have reacted. So coming to the advantage of its device, to the best of my knowledge, this is the first of its kind. The infrared cameras are available commercially, and we can choose any one of them. We chose this particular model because we had a ready-made app that could be integrated with that. Its documentation and objective interpretation is possible, and the ability to standardize is possible. I'll just go on. It's an effective teaching module. There's no lost opportunity, and then low cost. Can we have the video, please? This is the camera screen that appears. You can either, initially, as I said, we used light, but later on we integrated it with a light flash app in the camera itself, in the mobile phone itself, that could deliver the flash. But this was illuminating the whole face, as we can see in the next bit of the video. So what we did was, we tried to attach a conical attachment to the flash on the front side so as to get a collimated beam of light which would be more focused. And we sealed it off with black tape so as to prevent any light loss. So this was the modification which we did in the flash of the camera, and this is the recording being done. This is the patient with the corneal opacity, where the pupillary reaction, even as seen through the opacity, is so very clearly defined. So this patient, it is a strong indicator to the visual potential of this eye. We need not rely heavily on B-scan and VEP in these cases. This is a patient with a unilateral Addy's pupil. You can see the vermiform movements of the nasal aspects, whereas the temporal aspect is hardly moving. That's a typical vermiform movements of this pupil here. And that shows a tonic response to the near. This is the pupil in the normal state, and when the patient, the same patient accommodates, there's a tonic response. You can see the change in the pupillary size. This was the same picture that I was alluding to, the pupillary reactions, dark versus, this patient had an Addy's pupil on the left eye, and you can see the change, the anisocoria in light and darkness clearly points to the existing pathology already. So when there is anisocoria that is more pronounced in ambient light, that is a pointer to Addy's pupil. So thank you very much for your patient hearing.
Regarding corneal opacity, the thin grade corneal opacity is all right, but what about if
Yeah, that particular patient had a reasonably, almost a leukomatous opacity. I was myself surprised that it can penetrate. The reason is the longer wavelength of the infrared light doesn't get scattered and it passes through the corneal opacity. We checked that in several patients, but if it is a very dense vascularized opacity, we may not get the pictures. But even leukomatous grade opacities, we get good pictures.
Okay. But it's fine till macula grade or it's good. But dense leukomatous.
Very dense leukomatous, we may not be able to.
Thank you. Thank you, Dr. Kumar.